Good day. My name is Premila Webster, and I'm the co-editor of the Journal of Public Health supplement, Mental Health in India, Bridging the Gap. The supplement brings together some of the research related to mental health in India. In this interview, I talked to one of the authors of the research article, Factors Associated with Homelessness Among Women, a cross-sectional survey of outpatient mental health service users at the Banyan, India. So let me first introduce Dr. Lakshmi Narasimhan. Dr. Lakshmi Narasimhan is presently Assistant Professor in the School of Social Work at the Kumaraguru College of Liberal Arts at Coimbatore, India. Dr. Narasimhan has a master's in social work from the Tata Institute of Social Sciences and a multidisciplinary PhD from Vrije University, Amsterdam. She has been working with the non-profit organization, the Banyan, in the area of homelessness and mental health. She's also been part of various community-based services like Nalam, a well-being orientated, multi-interventional and social support service spearheaded by community mental health workers, and Home Again, a housing with supportive services intervention offering exit pathways out of institutionalized care for those with severe and persistent mental illness. Her interests are in understanding and developing social approaches for complex issues at the intersection of poverty, homelessness, and mental health. Dr. Narasimhan has published widely in peer-reviewed journals. Dr. Narasimhan, thank you for your article on factors associated with homelessness among women conducted at the Banyan, India. Firstly, could you tell us about the history and work of the Banyan, please?
All right. So Banyan is a non-profit mental health organization. We are based in Chennai, in India. Started in 1993 by two young women who were very moved at the state of a homeless woman with mental health issues that they saw opposite their college. And in trying to create a safe space, they started a shelter service, which has now evolved over a period of time into a formal institutionalized service delivery system for homeless people with mental health issues. And we've forayed, so the Banyan has in and through understanding homelessness, understanding in what context does it occur when people are affected by mental health issues, developed a wide array of services, which includes institutional services, but also a lot of community-based services. The emphasis is on social entitlements and social entitlements facilitation, looking at housing support, looking at social service supports. So we have three core models. One is the Emergency Care and Recovery Center, which is an institutionalized service delivery that works on community-based rehabilitation of homeless people with mental health issues. The second is Nalam, which is an outpatient-based service delivery that works along with community-based workers in villages to deliver proximal mental health care. The third is Home Again, that looks at housing with supportive services, especially for people who remain institutionalized long-term in various psychiatric facilities. And we work in close relationships with the government, and we replicate our models along with the government as well. Yeah, so that's the Banyan for you.
Thank you very much. Could you briefly give me a summary of your results and its implications both for further practice and research?
All right. So we tried to understand what were the factors that were associated with women becoming homeless. And we looked at a sample from the population that was accessing our own outpatient services, both in urban as well as rural context. So we first wanted to sort of understand how many of them report a history of homelessness. And we found that 3 out of every 10 women who had accessed the Banyan's outpatient services had a history of homelessness. So there was a significant number of people. And we tried to understand where the differences were and what sort of predictive variables were involved with people who particularly experienced homelessness. And two things stood out. So one, of course, was disruption of relationships, especially in the context of gender-based violence. That was one variable that emerged. And the more interesting variable that emerged was educational attainment. So women who had less than 5 years of schooling were much higher odds, almost 3 times, right? Were much higher odds of actually becoming homelessness if they had developed a mental health issue. And this sort of got us thinking, because the traditional sort of understanding is that you fix treatment gaps, you put a proximal service nearby to a person, and then you sort of make sure that they don't end up homeless. But majority of these people who had ended up homeless had actually accessed treatment. So they'd accessed formal psychiatric treatment in some form or the other. But despite that, given the concurrent social distress that they had experienced, had ended up homeless. So it was interesting for us to sort of examine what should practice look like then. So when a person with a mental health issue who experiences violence, who experiences this sort of disadvantage of not having adequate educational attainment, which goes into so many other domains of how much autonomy do you have, how much of resources do you have at your disposal. When somebody comes comes into a clinic, what sort of an encounter is it? Is it an encounter where you reduce their experience to, okay, symptoms, medication, so go back and you will get well? Or do you look at the health condition in the context of the social factors that are also affecting? So is it affirmative? Is it something that dismisses the violence they're facing, or does it acknowledge it and helps them navigate that better? So we thought maybe we need to sort of look at practice and how can practice, not just from a prevention point of view, but also from a proactive engagement point of view with somebody who's already undergoing a mental health issue. How do you actively work on social interventions that can sort of erase the structural violence that they face? So how should we look at those sorts of interventions? So I think largely that's the practice perspective that comes up. We also sort of looked at so it's a very homogeneous group of people that we looked at, right? So predominantly, although there were caste-based differences between those who had experienced homelessness versus those who didn't, predominantly all of them did come from disadvantaged castes. So, and are there neighborhood level deprivations therefore playing a role? That within a homogeneous community, why do some people end up homeless versus some people not ending up homeless? So is there something at a neighborhood level that we need to look at and investigate those sorts of factors better? So two major implications that stand out among many others.
Thank you. Banyan's obviously a remarkable charity and service that started a while ago by 2 young women, as you said, who saw and were moved by a homeless woman they found on the streets outside their college. Finally, what are your thoughts on what the future holds and possible solutions to bridge the gap of mental health services in India?
So there are two major areas that I feel the Indian mental health sector needs to work on. So the first is that majority of our investments, at least from a public health point of view, continue to be located in large psychiatric hospitals. Not to say that inpatient services do not have their place in a mental health system that works very well. You do need a certain proportion of inpatient beds, but that seems to be the one-stop solution. So you have not just in the public health sector, but also in the private sector largely. In Coimbatore, for instance, I find it hard to see outpatient services that are very accessible to people from low-income groups, for example, right? And again, a lot of institutional services, private hospitals exist. So how can we change this paradigm? I mean, we've talked about it since the 1970s, and looking at how can you make deinstitutionalization meaningful for people who are living with mental health issues, and can we truly create a paradigm shift and look at very, very affirmative community-based services? At the end of the day, what do people want? People want to live in a house, they want to be part of a family, they want to go for employment. So how do we work on those aspects, and how do we completely move away from those notions of beds and let's increase bed capacity, let's go and convert these into centers of excellence, but rather look at outcomes that people want to see for themselves. So I see that as one challenge that we need to sort of tackle. and the associated, of course, ideology in terms of how do you segregate people versus how do you include people in society. So that's one challenge. The second challenge really is to do with we've not quite understood social distress such as caste, gender, structural violence really, and how it interacts with people who especially face serious mental health disorders in an Indian context. So if we had to look at interventions, I think you need to do some work, in-depth work in understanding voices of people who have these sorts of intersectional experiences and seeing what is it that we can do so that they are able to move from the structural violence to alternate sort of pathways. So I think two important pieces of work that need to be done. And only then you're bridging your gap in terms of, okay, you increase services and therefore people access and they have better outcomes. That's going to work only if you fix these two gaps, I feel.
Okay, thank you very much. That sounds a really, good step forward, and hopefully you, with all the others who are working and with policymakers, politicians, and obviously the stakeholders who are the most important here, will be able to achieve some of these. Thank you very much.
Thank you so much.
Thanks for your contribution. Thank you.